Bismillahirrahmanirrahim. Today we will discuss Bismillahirrahmanirrahim. Today we will discuss and demonstrate the methods which we use for measuring a patient with ptosis. And I would like to make this video as short as possible because the concentration time is very low these days of audience, everyone, including myself. So in ptosis, it is defined as drooping of the upper eyelid. Patient comes with the complaint of that my upper eyelid has been drooped for the last 2 months or 1 year or whatever. Then I am skipping all the theoretical things and all the other tests. I will just perform 4 specific tests which are exclusively done for a case of ptosis. Other tests like extraocular movements and cover tests which are performed in Squint, they are also performed in a case of ptosis, but the exclusive tests which are performed only in ptosis, I will perform in this video those tests. Number one is MRD. MRD stands for marginal reflex distance. It is the distance between the upper eyelid margin, and when I show the light, I will show the light in patient's eye. A reflex is seen on the cornea. The distance between the upper eyelid and that corneal reflex is called marginal reflex distance. Normally it is 4 to 4.5 millimeter in most of the people, and we check it bilaterally. I have chosen a point, and 0 is at the upper eyelid, and I can see it exactly 4.5 millimeter. Now I am checking on the other eye. We will ask the patient to look into the torch, okay? And here it is also 4.5. It means it is normal. 4 is also normal. For example, in a patient of ptosis, obviously it will be decreased. The MRD is 2.5. You subtract the MRD from the normal MRD. It will become 2 millimeter. The 2 millimeter figure is the severity of the ptosis. We will say that the patient is having a 2 millimeter ptosis in his right or left eye. Got it?
Yes.
Now we go to the second test. Second test is to check these are very simple tests but very important and very diagnostic. Second test is to measure the vertical fissure height. That is the distance between the upper eyelid margin and the lower eyelid margin. Again, it will give us the same information, but methodology is slightly different. Now, I will ask the patient to see straight ahead, and I will place the ruler over the upper eyelid, and I will check the lower eyelid and the distance between the two, and make sure that it is in the center, not in the periphery. We'll do the same in the other eye. Please don't blink. And it is almost 10 mm of mercury. 10 millimeter. Normally it is 10 to 12 millimeter. In females it is 2 millimeter larger than the males usually, by default, by nature. In a patient of ptosis, it will decrease. He may have a vertical fissure height of 4 millimeter. It is very a thing of common sense. There is no such thing to discuss about it. The third test which we perform is the upper eyelid crease. Upper eyelid crease is the crease which you can see on the upper eyelid. Like here you can see a crease. This crease is made by the insertion of the fibers of the levator palpebrae superioris muscles aponeurosis. 90% of the fibers are attached on the tarsal plate, if you remember the anatomy of, recall the anatomy of the eyelid, and the 10% fibers are inserted to this skin, and these are the fibers which make this skin. In old age, these fibers are become descends, weak, or torn away, and upper eyelid becomes absent, and eyes become. You might have seen very our old people who have sunken eyes because upper eyelid is creased and they have retracted the skin backwards. So that is the most common cause of senile ptosis or aponeurotic ptosis, usually we call it. And how we check it, we ask the patient to see as low as he can, but not don't close the eye. So please see below. Now you can see, if you can zoom it, a very slight line. It is not a very prominent. In some people it is prominent. With the same method, I have placed 0 at the upper eyelid crease, and I am checking the distance between upper eyelid crease to the upper eyelid margin. When I am looking down, I am checking the distance between the upper eyelid crease and upper eyelid margin. Got it? It is also between 10 to 12 millimeter, and same in the other eye also. In senile aponeurotic ptosis, it will be absent. Normally it is present. In congenital ptosis, it is usually it is a dysmyogenic ptosis in which the aponeurotic muscle is not properly developed. Congenitally also it is absent, and the patient, the child usually has ptosis. The last test, the fourth one, is called upper eyelid excursion. Upper eyelid excursion is basically a test which we do to check the function of the levator muscle, to see how much power the levator muscle has. There are two muscles basically around the eye. One is orbicularis oculi, which is like a purse in a rounded fashion all over. Excuse me, sir. How much power the levator muscle has, because this is perhaps very important test, because excuse me, the power in the levator muscle is the basis upon which our surgical plan is based. So how we perform it? For this, you will ask the patient to see downwards, okay? And if there is enough light, you can do it without torch, and then you will place your thumb on the eyebrow. The purpose of placing the thumb is that he may not use his frontalis muscle. Okay. When I have done this, I will place any point of this ruler at the upper eyelid margin, which is lowest. Okay. So it is 3 or 4. I take it 4. Now I will ask him, please follow my command. See as up as you can. Okay. Now I have measured how much distance his eyelid has covered, has from lowest point to the highest point. It is 20 millimeter. Normally it should be more than 15 mm of mercury. If it is below 15 mm of mercury, then it is fair levator function. If it is even lower, then it is poor. And there is a classification If it is less than 5 millimeter, it is non-functional. These theoretical things are written. But if the levator has got good levator function, then our surgery usually our first choice is to resect the levator muscle. For example, if this is the eyelid, okay, and it has become ptotic like this, we will by measurement uh, we have measured that it is 4 millimeter ptosis, which is moderately severe. Then with the special formula, we come to know if we will cut uh, 5, 6 or 8 or 7 or 3 or whatever the number of millimeter of this elevator, which will correct a specific number, a specific number of processes. So for example, we cut 6 millimeter of elevator uh, by dissecting the skin, separating the subcutaneous tissue or utilized muscle, and finding the levator, and then by a gauge measuring carefully. For example, we cut 4 or 6 millimeter, and then we resuture the both cut ends. You're getting my point? And this will what will it do? It is shortening of the levator. The toticate will become like this. So on special formulas, we know that for how much doses, in simple words, in how much doses, how much resection should be done. This is you can do it with practice. You come to know, and there are tables and other formulas which tell you how much you have to do it, and that is all as far as the uh, special tests which are done for process. Thank you very much.